Thank you all for joining me today. It's an opportunity for us to begin sharing with the community some of the positive things that we think certainly are possible with this potential partnership between Franciscan and Methodist. You know, one thing that all the business leaders in this room today have in common is that every day in our leadership roles, we're charged with managing human and capital resources in order to achieve success in our organization. But I would also tell you that there's a third asset that we as leaders and managers have to manage, and I will call you and tell you that that is something called the future. The future is an asset that has to be managed in just the way we manage capital and human resources. And every time we look at the trends in our industry and see where they're going, we have to decide what we have to do in our particular organizations to make sure that we maximize the opportunities that we see with those trends or minimize the liabilities that we see with those trends. Think of all those organizations that tried to buck the trends in their industry, those legacy organizations that are no longer around today because they misspread the trends in the organization and the environment and made wrong decisions or waited too long to make the right decisions. And it's in that vein that I would suggest to you that our board of directors about a year ago began to ask the question, should a partnership discussion be a part of our strategic look at the future? Our decision to evaluate whether we should remain independent or seek a partnership with another organization was really something that's rooted in the basic steward obligation that our board has to assure that our hospitals continue to be able to provide care, address the healthcare needs of this community in perpetuity. And that's what we had in mind when we began to evaluate this partnership opportunity. Now, I will be honest with you and tell you that this is a topic that's on the agenda of every board, every hospital board across the country. These dialogues are occurring in hospital boards rooms across the country, given the way that healthcare is being delivered today and the way it's going to be paid for in the future, and given the way we have to respond to healthcare reform initiatives. I would also tell you that from a strategic perspective, this is really one of the biggest bets that Methodist will make in the future. And it's a big bet because it's going to have a material impact on what our organization looks like, whether we do it or whether we choose not to become affiliated with another organization. It's a big bet because in many ways it offers us security, it offers us peace of mind, and it offers us an opportunity to really devote ourselves to long-term improvements in the quality of care, access to care, and the cost of care. I would also tell you that if we remain independent, we have to think about the trends out there in the marketplace. More than 250 hospitals have joined systems in the last 10 years. And they've done that, quite honestly, because preserving independence is fraught with risk in today's healthcare environment. If you look at what the strategic planners are saying about healthcare, they will tell you that in 2017, the healthcare industry will continue to consolidate through mergers and acquisitions. It isn't going away, and for a lot of good reasons. If you talk to most of the CEOs of large healthcare systems, they will tell you that the idea of the standalone hospital is gone. People can't afford to be a standalone hospital anymore with the kinds of investments that need to be made in order to be successful. Now, there are two sets of drivers that are creating this scenario. One is operational finances. Some hospitals just need access to capital in order to compete. There are also some that have clinical deficiencies, and they need to partner with another organization in order to build up their clinical programs and continue to serve their communities. The other reason, the other driver for this trend is what we would call strategic. And it's strategic because the second bucket, the strategic bucket, these are organizations that tend to be relatively strong financially, that are considered to be strong community-based providers like Methodist and their marketplaces, but they are looking at the landscape of the evolving healthcare environment and saying to themselves, quite honestly, the same question that we're asking ourselves as Methodists: do we have the skills and capability to be successful in this new era of value-based care? Hospitals are joining large organizations for a number of reasons. As I said, staying independent is very, very difficult. It's difficult because you have to have money to make investments in electronic medical records. You have to have money to invest in capital, and you have to have money to acquire the latest and the greatest technology. They're joining larger organizations because it's harder to recruit talent. Some of these positions are very expensive to hire. I need to hire a neurosurgeon in my organization. To get a neurosurgeon, I'm going to have to pay about $700,000 a year for a neurosurgeon. And so we know that we're better positioned to try and recruit this type of talent if we are a part of a larger organization. We also know that to be successful in today's healthcare reform environment, we've got to bring on more primary care physicians, because the whole goal is to keep patients out of the hospital, not to put them in the hospital. So we want as many primary care physicians as we can spread throughout the community so that we can improve the health of the community in the community without that patient having to come into the hospital. If we join a larger organization, it gives us access to a better reception in the capital markets, because we'll have a stronger balance sheet behind us to get rates at a preferable rate to make the investments that we need to make. And hospitals are joining larger organizations in order to prepare for population health. It's not about caring about the individual patient really anymore. If you want to be successful in the new healthcare reform environment, you've got to be able to demonstrate that you can take the risk of caring for a defined population of patients, because that's how the insurance companies are going to pay you, and that's how you're going to be rewarded. So as we looked at all of these trends that I just talked about, we made a decision that probably a relationship between Franciscan and Methodist might offer us the best path forward to dealing with the challenges that we see coming down the pike in terms of healthcare reform. So, how did we go about making this decision, and why did we select Fransiscan? Well, we went through a very detailed, competitive process. We hired a financial firm out of Chicago called Juniper. They went out to the market, and they basically brokered our organization. There were 37 organizations that were approached to see if they were interested in a relationship with Methodist. All of them took a great look at our organization, a very deep look at our organization, and many of them suggested, yes, we'd like to continue the conversations. But we narrowed it down to those that we thought were reasonable. We had requests from for-profit organizations. There were teaching hospitals that expressed interest. There were a number of community hospitals that expressed interest. There were systems in other states that expressed an interest in working with us. But we narrowed it down to those local organizations that we thought would make sense for us from a local perspective. And I will tell you that the final one we selected out of all of those people, all of those organizations, Fransiscan was the only one that was willing to support our mission of caring for indigent patients in the Gary community. The only one that was willing to support our mission of making sure that no patient got left behind when it came to access to care in the Gary community. The only one. And they were the only one that was willing to come to the table with support to improve our healthcare services in the Gary community. And they were the only one that was willing to work with us in getting a modification of the consent decree that would allow this project to move forward. The cornerstone of this project is in 3 areas. First of all, Fransiscan has agreed to build a replacement hospital in Gary at approximately a cost of $300 million. They will also agree to fund all of our improvements at our South Lake campus that will amount to about $75 to $100 million. These are all things we'd have to do on our own as an independent organization. And I'll be quite honest with you, we could do it, but it would take us an awful long time, and our competitors would really get ahead of us. We could do it, but it would change our balance sheet significantly, because we'd have to go to the bond market to borrow money. And once we went to the bond market to borrow money, we think that our bond ratings would begin to decline because our balance sheet would be strained to make these types of investments on our own. They were the only organization that said to us, we will help you reestablish your medical education residency program. Methodist had a family medicine program some years ago. They got rid of it. That's how you grow your medical staff, through a residency program. Because those young residents and doctors, they come through your organization, they work with your attendings get to know them, and eventually a relationship is created, and they might decide to stay at your hospital because of that training experience that they had at your organization. That's what used to happen at Methodist. It doesn't anymore because we don't have a medical residency program. And I will also tell you that as a part of this deal, they had agreed to build us a new medical office building that would be right next to the new hospital. So, not everybody was willing to do this. Now, at the end of the day, if this deal goes through, somebody in the state's attorney's office is going to ask the question, how do we know you made the right decision? How do we know that you made the decision that was in the best interest of your shareholders, the patients and families that you care for? Now, I'm a not-for-profit organization. I don't have any really shareholders, but whenever I improve the health of the community or the health of somebody in the community, I pay the dividend to my shareholders. And so these companies are going to look at us and say, why did you make that decision? When they see what was on the table, they're going to say, you made the right decision from a business perspective. So, what will this new hospital look like? This is an artist's rendering of what this new hospital will potentially look like. It is going to be a duplicate of the hospital that's being built in Michigan City today. If you ride down 8094, you'll see that facility under construction. We also know that it means a lot for Gary. The discussed location for this new facility is along 8094 in close proximity to the IU campus. Now, why is that important? Now, obviously, all of this has to be approved by planning commissions and everybody else, but that's the vision that we have in mind. Why is this location so important? If you're familiar with the medical district in Chicago, where you have Rush, Stroger, UIC, and you look at all the development around that, you begin to plant the seeds for what can happen in that community if you put education and clinical practice together in that environment. And you begin to draw other businesses to that community. So we think that that's a positive. What does it mean for Gary? Obviously it means a new replacement hospital. And the mere fact that we're going to construct a new hospital means new jobs and more jobs in terms of construction. It means that we will continue to be able to employ all of those important hospital jobs that we need to have in order to provide good care. And it's also, as I mentioned, an opportunity for economic development. When you look at construction, the estimates are that over 1,000 construction jobs will be created as a result of this. And we think that's an equivalent of 350 full-time jobs over the 2 years that it would take to construct this hospital. That's going to impact local workers, it's going to impact vendors, it's going to impact suppliers. Now, it will probably take us maybe a year or two from the day we sign a definitive agreement to begin construction because we got to get all these approvals. But once that construction is completed, and we think it'll take about 2 years, I think overall we'll be in pretty good situation. I talked about the medical office building. This new medical office building will have space for 10 to 20 physicians in their clinical practices. And this is important because physicians need to be close to the hospital so that they can manage their office practices, but at the same time have access to seeing their patients. Patient comes in to see the doctor in his office, gets referred over to the hospital for ancillary services. It all works together. It creates synergy between the practice that the physicians manage in their offices and the need for ancillary services in the hospital. One of the questions that's been out there is, what does this mean for patients? And will we duplicate all the services that we have today at the Methodist Gary facility? And the answer is yes. There'll be a new emergency department. We've already got a new emergency department. It's just open. It's beautiful. But it might take us 4 years to get to this point. So in the meantime, we're going to be using the existing emergency department. But yes, we will have a new emergency department, and we will have a trauma center. All the services that are in the Gary Hospital today will remain in the new Gary facility. Now, we are in the process of going through the development of a service redistribution plan using an outside consultant to help us decide, once we put all these hospitals together, it will be a total of about 7 or 8 hospitals that would be a part of this new Fransiscan structure, we're looking at what services we should have at each hospital. What are the core bread and butter healthcare services that need to be at each hospital? And what are the centers of excellence, and where are they best positioned in the marketplace to provide care to the entire Northwest Indiana region that we would be charged with caring for? The new hospital also includes OB units. All the OB units that we have today will continue to be in place in this new hospital. And we've just remodeled some of those OB units at our North Lake facility. And so my point here in telling you all this is that one of the questions that has come up is, well, what service are you going to put in these new hospitals? Are you going to take anything away? The answer is no. Whatever services that we have today will be continued into the future. So, what does this partnership mean, basically, for patients? It means improved quality. Now, why does it mean improved quality? Well, remember, I told you, it allows us to have a larger base of primary care physicians and a larger base of specialists. You can't cut off the traffic to Chicago unless you bring in more primary care physicians and more specialists into Northwest Indiana so that they don't have to make choices about going to Chicago to receive those types of services. And it keeps care local. It keeps care local. Right now, we refer patients to Chicago because we have to. But as a part of a larger system, with the capacity to develop these kinds of resources in primary care and specialty care, why do you need to go to Chicago when you can get the best care possible right here at home in Northwest Indiana? Think of this. 8 hospitals all together, one common electronic medical record. No matter where you go in any of these hospitals, we've got all your data in a system, and we can treat you. We know all your background, demographic information, and everything else. And it just makes care much more coordinated in terms of responding to your needs. We're able to share data. And so no matter where you go, if you're in an accident, you get taken to one hospital, we've got all your data. That's improving the quality of care. It also means job creation for the hospital field. I always tell young people that making a choice to come into the field of healthcare is a very wise choice. And it's a wise choice because they make 2 decisions. One, they choose to go into the healthcare field, which is one of the fastest growing markets out there. It's almost recession-proof when you think about it. You can really achieve all your professional and personal goals if you have a career in healthcare. The second reason I tell them that it's a wise choice to go in healthcare is because hopefully they've chosen to come and work at Methodist. And so we try to build that part into it too. But all the clinical occupations that exist today will continue to be available in the new hospital. When you look at the community economic development aspects of this, as I mentioned, if we can create that same kind of medical district that exists in Chicago, it's going to have an impact on drawing new businesses into the community. Now, in the city of Gary, I think everybody recognizes that there is an imperative for development. Fransiscan's commitment to invest $300 million in a new Gary hospital will represent the largest development initiative in the Gary community in the last 38 years. The largest. Now, the population of the city of Gary since 1975, when the consent decree is in place, I'll talk about that later, has dropped by almost 100,000 people. If you walk around the city of Gary, and these statistics have been posted in the newspaper, I didn't make these up. You look at the number of vacant buildings, 42% of the land is vacant. I understand it takes about $40 million to demolish homes, some 6,500 abandoned buildings. You've got low tax revenue and you've got lingering tax appeals. In that kind of environment, we should be welcoming new development because it will pull the whole community up and everybody benefits. Now, if you paid attention to the news lately, you heard about Walgreens closing a store over in Miller, okay? You've heard about Family Dollar starting to close stores as well. Well, these organizations are closing because they can't see their way economically to success in the locations that they are in. So they're leaving. But to Methodist credit, we're not leaving. We don't make a lot of money in that Gary hospital. I've got 2 hospitals. I've got a safety net hospital and I've got Maryville. They're inextricably linked. I need both of them to be successful. But I don't make a lot of money in Gary because I care for an underserved population. Now, the cost of that care obviously is offset by dish payments that come into the hospital, and those are very, very helpful. It allows us to continue to support that community. But we're not making the decision to leave. We're trying to figure out a way to assure that healthcare services in Gary continue to exist in perpetuity, because we know we can remain independent for a short period of time, but sooner or later, the economics of healthcare is going to catch up with us. And we're going to be in the same situation as a lot of other hospitals that run out of support to provide the kind of care, and most importantly, to compete. And that's what worries us the most. We will not be able to compete with some of the other systems if we don't start making some significant investments and taking advantage of opportunities like this for success in the long run. So while other organizations may be reducing their presence in Gary, we are honoring our irrevocable commitment to Gary that no patient should be left behind when it comes to access to care. However, I will tell you that if we maintain the status quo, the character and the style of medicine that is practiced, and the success of our organization will require sustainability that will not happen by accident. If you look at the business case, really, for a partnership, it's pretty simple. This is why a blueprint for a partnership is going to be a success. It allows us to expand our primary care and specialty positions. It allows us to have a broader focus on outpatient care. It allows us to quickly adopt the patient population health and value-based care. If you don't know what value-based care is, right now most of you are probably familiar with fee-for-service. You go to the hospital, you get a bill from the doctor, you get a bill from the hospital, you get a bill from the radiologist, you get a bill from the pathologist. And value-based care is one bill. I get paid for outcomes of care. If I don't deliver on the outcomes that the federal government thinks should exist, I get docked for my payment. That's the kind of environment that we have to be successful in the future. It improves our access to capital markets at better rates. And yes, we do believe that it does allow us to, in the long run, invest in quality access and the cost of care. Our market share is not growing. If we're going to grow as a system, we have to take business from another organization. Part of my catchment area is in that lake out there. There's no patients in that lake. So I've got to look elsewhere to grow my organization. And that's what this partnership allows us to do. Remember, it's not a Gary Hospital. There's not a Maryville Hospital. There's one Methodist, two hospitals, inextricably linked, and we've got to stay focused on the success of the entire system, because that's the only way everybody's vote will rise in this equation. When we look at our capital requirements going forward, our average age of plan in Gary is about 18 years. If you want to be a highly bond-rated hospital, you need to have an average age of plan of around 11 or 12 years. The older your plan, the more investments you're going to have to make in keeping that facility maintained. We invest about $8 million a year annually in facility maintenance now. We've got a $162 million master facilities plan on the table that needs to be funded. Some of that plan has already been implemented. We've opened a new ED. If you haven't visited that new ED at Northlake, it is really a first-rate, first-class organization that I think every citizen in the city of Gary would be proud to come to and receive care. We've opened up a new medical ICU. We've opened up a new surgical ICU. We're investing $25 million in bringing new physicians on in the very near future. And we know that in order to really fund all our capital needs, we need to go to the bond market. And given our current balance sheet, the most I can go to the bond market and get is between $35 and $45 million. That's not going to fund the plan that we have to sustain services in the long run in the Gary community. If it doesn't sustain it, it means I got to take it out of operations. As soon as I start taking it out of operations, my balance sheet begins to go in a different direction. So, bringing these two organizations together would really give us scale to be successful in a population health model and take appropriate risks. If you look at every successful healthcare system out there today, they're characterized by 4 different things. And I've had the privilege of working in some very fine organizations. First of all, they have great geographic coverage. Why is geographic coverage important? It's important because it gives us a competitive advantage in the marketplace. Look at all those, I'll call them shields on the screen here. Those would be all the hospitals in the new system that we would be a part of. What I'd like to do is I'd like to be able to go to Cynthia Bank and say to the Cynthia Bank people, I want you to send all your patients, all your employees to my hospital. Send them to my hospital. And I can prove to you, I've got 25,000 employees that I care for in this system. If I can prove to you that I can reduce the cost of care for those 25,000 employees by 25%, I'll take that same model into your company and I'll reduce your cost of caring for your employees. And I'll give you half the money back if you send, and only if you send, all of your patients to my hospital and my doctors. Well, as a two-hospital system, I can't do that. I don't have enough bandwidth to do that. But if you're a part of a larger system, Cynthia's got people all over Northwest Indiana. They can't say to me, well, you don't have enough doctors, you don't have enough hospitals. If I make them a good enough deal, they're going to look seriously at it, I think. So that's one of the advantages of having geographic coverage. When you have geographic coverage, you can go to the insurance companies and they can't walk away from you because you got too many patients and too many hospitals and too many doctors. And their patients need somebody to come to. The people they insure need someplace to go. So the larger I am, the more of a relationship I can develop with the insurance companies. Successful organizations have robust position alignment strategies. I have 45 employee positions. If we complete this deal with Fransiscan, we've got 500 employee positions. 500 positions working together, aligning their incentives with the hospital's incentives, prepares us to deal with changes in the healthcare environment. It prepares me to deal with bundled payments. Let me tell you what a bundled payment is. In a bundled payment, I get paid one payment per episode of care. If you come in for a total hit, I might get $75,000. Okay? One payment. I have to split it with everybody who was involved in your care. And a lot of people are involved in your care. Well, as a two-hospital system, I can't do that. But as a part of a larger system, I can do that. And if all the positions are working together to control the cost of care so that that pie can be spread better among all the participants, who's going to disagree with that from an economic model decision? It allows us to focus on quality, and I talked about quality a little bit. People don't have to go out in the community to get the care that they need. And it allows us to focus on cost improvements. So, what are some of the frequently asked questions that we get? What is the significance of the letter of intent that we've signed with Fransiscan? And does this mean Methodist Hospital will combine with Fransiscan Alliance? Yes, it does. It means that it's a merged asset arrangement. They take over our assets. They take over our liabilities. We basically become a Catholic hospital. In terms of our boards would be merged. Fransiscan has about 4 regional boards throughout the Indiana area. The Northwest Indiana board, our entire board would go over and join that board. We would have more Methodist people on that board than there are Fransiscan people on that board to begin with. We would, in terms of the timeline for the process, we're going through due diligence now. We anticipate that it will probably take us through the end of the year to complete that due diligence process. What service lines will stay at our hospital, and will there be service lines eliminated or moved to other facilities? As I mentioned before, we're going through an evaluation process now to make those decisions, but whatever we do, we're going to respect the safety and security of our employees and our patients, and the agreement that we have is none of the services that exist at Gary today will be negatively impacted. Our employees often ask, how will this partnership impact my job? It won't. The agreement that we have is that everybody who has a job today will have a job when this definitive agreement is reached with Fransiscan, if we get to that point. How will this partnership affect my current benefits, such as seniority, PTO, and insurance? All that stays the same. In the letter of intent, we've made arrangements. Whatever benefits you have today, it's carried over to the new organization. Will our culture and leadership remain in place under a partnership with Fransiscan Alliance? All the management staff that exists or that is on board today at Methodist will be carried over into Fransiscan and will continue to run the hospitals. So that our doctors, our patients, our employees will still report to the same management team. And That's how you assure that the culture isn't obliterated, because your leadership people will still be in place. Are you planning to engage staff throughout the due diligence process? Absolutely. You can't do due diligence without engaging the staff. We're meeting with our staff regularly. We have a marketing plan. We have spirit talks with small groups of employees. We've begun a process of having the management staffs at each of the hospitals begin to meet and learn about each other and the services that we provide. We can't do a lot of planning because we're not merged yet, and it's against the law to do that. But you can introduce people and you can start talking about the services that each of your organizations provide. How will we keep the public informed about updates and decisions? This is kind of the medium that we're at today. I'll be going out. I'll be the face of this in the community. And we're going to have a lot of different meetings to make sure that people stay up to date on what we're doing. So, what role does the consent decree play in this process? And you've probably heard a lot about this. Does everybody know what the consent decree is? Okay. A few people know. In 1975, I think it was around 1975, Methodist Hospital had built Maryville. And there was a concern that all the hospitals were leaving Gary. The old St. Mary's Hospital had left and moved to Hobart. And at that time, the concern was that Gary would be left without a hospital. So the city of Gary sued Methodist at the federal level. And in order to resolve the suit, Methodist had to agree to a consent decree. That consent decree was the right thing at the time, because I think without it, there may not be healthcare services in Gary today. That was over 40 years ago. Now, what the consent decree does, it requires Methodist to go and get approval to spend $100,000 every time we want to spend $100,000. It requires Methodist to duplicate and create parity between what we do in Maryville and what we do in Gary. And as I said, in the new healthcare reform environment, you can't duplicate services like that and think that you're going to be successful from a financial perspective. But you can honor the access to care that every patient should have, no matter which hospital they go to. And you can figure out ways of getting those services to those patients without duplicating all of those services. We don't know that that consent decree can really embrace all of the new challenges in healthcare reform. Methodist is the only hospital in the state of Indiana that operates under a consent decree. There's not another county, another hospital in another county, another hospital in another city, another hospital in another hamlet, another hospital in another village that has to operate under a consent decree. As I said, every time I spend $100,000, technically I have to go get permission to spend the money. In healthcare, I can spend $100,000 just by snapping my fingers. But fortunately, I think the Office of Civil Rights understands the constraints with the consent decree, and we've figured out ways in some cases to honor all the things that we have to honor. We have a master facilities plan that has to be approved by the Office of Civil Rights, and we are in full compliance now with all the requirements of the Office of Civil Rights as it relates to the master facilities plan and what they have approved. They've approved us spending up to $160,000 to support Gary as well as our Maryville campus. Now, in 1975, you could live under a consent decree because we all operated under cost-based reimbursement. Whatever I spent, I got reimbursed. I don't get paid that way anymore. The consent decree does not embrace the principles pushed by the Affordable Care Act and commercial payers towards population health management and risk-bearing value-based care, which requires economies of scale. That consent decree does not take into effect the social and economic factors in Gary that lead to readmissions to my hospital. Patient leaves my hospital, comes back within 30 days, I don't get paid for that. Well, in Gary, there aren't always enough support services to care for patients in the community. So they end up coming back into the hospital, and we end up having to take care of them and not get paid for them. Well, the consent decree doesn't recognize that. If you follow the consent decree, you got to provide those services whether you're losing money or not. That's not the way to run a business these days. It doesn't recognize the labor-intensive infrastructure to manage length of stay in a population health management model, so to speak. As I said, in 1975, Gary had a very high population. That population has dropped somewhere between 80 and 100,000 people since that consent decree was signed. Where are all those people going? Some of them are probably going to Maryville. Some of them are going to other areas. But the ones that remain, because of the Affordable Care Act, don't have to choose my hospital. They can wait where they want. Because the Affordable Care Act gives them the flexibility to say, I want to go to this hospital, I want to go to that hospital, but I got to live with a consent decree. So I got to provide the services whether you decide to come to me or not. That can be a challenge. But I think a lot of people in the Gary community feel comfortable at our hospital because they know our people and they know that we care about them and that we're not going to deny them access to care. So for all those reasons, we think it's time to modify that consent decree. And a modification will be a condition of moving forward with this plan. Now, there have been, as I said, a lot of issues with the consent decree. Signed in 1975, parity is important. It's not practical in today's environment. So, if you read the newspaper this morning, in the Northwest Times, there was a headline that said, "Merger causes concerns." And if you read that article, it was about the ethical and religious directives of the Catholic Church, which, if we become Catholic, we have to honor those ethical and religious directives. Catholic hospitals cannot do abortions. We don't do abortions. Catholic hospitals will not do transgender procedures. We don't do transgender procedures because we don't have the capacity to do them. Catholic hospitals cannot do tubal ligations. Women have to choose another option or another hospital in order to get that service provided. Catholic hospitals don't do vasectomies because they're focused on promoting life, so to speak. And so people have to make other choices about where they want to go for those services. This is a concern to us because we felt we needed to offer an alternative for people who wanted to make that choice. So what we did in the letter of intent was agree to carve out a certain amount of money from our balance sheet and to provide economic support to an organization that would be willing to provide that type of service. And there are examples around the country today of how that works. And some of those examples were articulated in the article that was in the paper today. So there are options. But I only did 120 tubals in the last 15 months. It's not that big a part of my operation. There's the issue about birth control. Well, they figured all this stuff out. And women in the Catholic health system still have their choices on contraceptives. They still have those choices. Those choices are always a decision between the patient and their physicians. And I'm not an expert on the ethical or religious directives, but I don't think there's anything in there that's going to harm patient care as we move forward with this merger, and we're willing to support in any way we can alternative services that would be available to people who want to make those choices. And so we think that the Fransiscan Partnership is the path forward for Methodists to preserving sustainable healthcare services. And the basic question is this: should we at Methodists manage the future, which is what we're trying to do with this partnership with Fransiscan, or should we manage the status quo, which is what we will do if we don't do this merger and we can retain the consent decree? So for us, it's a good business decision. In conclusion, we think it will support growth, it will support physician recruitment and development, it will support quality improvement, it will support academic endeavors, and it will support clinical synergies and costs. Now, one final slide. Again, if you look at Merrill Lynch, what they're saying here is that margin pressures are increasingly prompting organizations to reassess their core missions and capabilities and subsequently turn to partners who can evaluate or strengthen the disciplines outside the realm of high-quality patient care. That's what we're trying to do. That's where the industry is going. So I hope that has helped you to understand the business decisions that we're trying to make and where we're trying to steer our organization as a result of this partnership. A lot of work still needs to be done. We don't have a definitive agreement. We've got a lot of things that we got to work out, and we'll keep you posted. Thank you for your time.